Good morning. I just want to thank the organizers again for the opportunity to speak with you all today. So, as at least some of you are aware, desmoid tumors are benign but locally aggressive neoplasms that derive from fibroblasts. And while these tumors are relatively rare, especially at tertiary care medical centers, you seem to have a lot of patients that are dealing with chronic symptoms and morbidity from the tumors. So this can be in the form of functional limitations or pain or neurogenic symptoms. Most often these tumors are sporadic. There's often a vague history of trauma associated with them, but they can also be associated with certain hereditary syndromes. So conventional treatment for these tumors is not so great. You can operate on them, but there's a relatively high rate of recurrence, and our local orthopedic oncologists, I don't think, have operated on them in the past 2 years. Radiation is an option, works about 70% of the time, but doesn't necessarily decrease tumor volume, just slows growth. And these are often young patients that we don't want to be irradiating. Chemotherapy is an option, but there's no magic bullet agent that works consistently, and there are significant toxicity associated with some of the regimens. So even with combination treatment, recurrence rates are as high as 40%. Focused ultrasound has a favorable side effect profile for ablation, and so at our institution it's really become first-line therapy. When we're discussing these cases in sarcoma tumor board, if it's feasible to treat a patient with focused ultrasound, we do so. So we've performed 14 treatments in 7 patients over about the last 18 months, getting non-perfused volumes anywhere between 30 and 85%, depending on a number of factors, and these are typically young patients. I wanted to highlight a few treatments that we've performed specifically in the thigh. I feel like it's a good area for discussion because these tumors can be particularly large in volume, and they can encase or displace a critical structure, the sciatic nerve. So the first case, this is the first case we ever treated, is a 7-year-old boy. He had had near complete resection and intraoperative radiation therapy about 2 years before he came to see me. He went on to have vinblastine and methotrexate, but had continued growth of his tumor. He then went on to have sorafenib, which is a kinase inhibitor, and had severe total body dermatitis that resulted in a week-long hospitalization. So he was referred to me. This is his tumor, obviously very large within the anterior compartment of the thigh. Coronal contrast image here, see very solidly enhancing throughout with these fibrous septae. So we brought him in for focused ultrasound treatment and had a pretty good treatment result with a dense non-perfused volume. Essentially, you can see just a little rim of enhancement there. So happy with that. 96 sonications on average over 2,000 joules. Pretty large tumor volume for a respectable non-perfused volume of over 50%. But we did unfortunately have a 2nd/3rd degree skin burn in the far field skin. So despite the fact that we got great heating within the center portion of the tumor, enough sound energy propagated through the far field and hit that air-skin interface like a wall and created a burn there. But despite the burn, the patient's family, the referring clinicians were really happy with the treatment result and wanted to proceed with more treatments, and that had us thinking about what are the ways that we can best protect the far field skin. So clearly you could use less energy, but you potentially will have a less effective treatment. You can use fiber optic probes to directly monitor the temperature on the far field skin surface, and we've done that on occasion, particularly when we're doing large volume ablations. You can use far field coupling agents like a water bag, which we like to chill down several water bags and like those because we can conform them to the far field skin. We can also look directly through the water bags periodically during the treatment and get a sense of if any changes are happening at the skin. Gel pads are another way to go in the far field. So this is an example of using that water bag device to protect the far field skin, and nicely on the MR thermometry images you can see these eddies going through that water bag. So we've brought him back several times for treatment. His tumor is so large and he's relatively young that we haven't attempted to ablate the entire thing in one session, but have been bringing him back periodically for treatments as necessary and seeing progressive decrease in tumor volume and improvement in his functional symptoms over time. So to the point most recently he's had over 85% non-perfused volume in the tumor mass. There's a cine loop through that tumor. You can see really dense non-perfusion with some peripheral nodular enhancement. So just briefly, moving on to the second case of a 14-year-old girl who had never had any prior treatments. In this case, the tumor is more posterior and it's encasing the sciatic nerve. And we can see that nicely on the sagittal images, the sciatic nerve in the anterior aspect of the mass. So because of that, you can imagine orthopedic oncologists in particular will not want to touch this kind of tumor for resection with the nerve being there. And we were a little bit timid in our approach initially as well. So because of that, we only got a relatively low non-perfused volume of 30% during the initial treatment. You could see sort of patchy areas of enhancement centrally. We brought her back. Her tumor basically completely recurred in the areas we had treated. We brought her back and turned up the energy, slightly adjusted the positioning to allow us to spare the sciatic nerve and feel more confident in increasing energies. We're able to get a more nice, dense, non-perfused volume posteriorly, leaving a rim of enhancing tissue around the sciatic nerve and also improving her functional symptoms. So I was quite happy with that treatment result because I think it really highlights the fact that focused ultrasound can be really precise and excise tissue in ways that other standard approaches are unable to do. So another key thing with this treatment is that we had to use relatively higher energies compared to the first. That seemed to be really key, and I'll highlight that the thermometry for a given sonication was not quite indicative of an improved treatment result relative to the increased energies that were used and obviously the larger number of sonications. So in summary, focused ultrasound rapidly becoming a first-line therapy for desmoid tumors, and large volume treatments near critical structures are challenging but certainly feasible. Thank you.
To open it for questions. I'll ask one question. For the sites that you have not ablated, for the partial ablations, do you see regrowth of those areas during the interval treatments?
It's kind of interesting. It seems to relate in some ways to the size of the initial tumor. So we've had a couple of fairly small tumors, maybe 3 centimeters of maximum diameter. We've only partially ablated, but then get on to see them just consistently shrink over time ever since. But then for the very, very large tumors, if we only partially ablate an area, that does seem to come back. Or the area around it seems to infiltrate that area. So.
Any other questions? All right, thank you.